You've been doing everything right. The morning medications, the low-sodium meals, the blood pressure cuff on the nightstand. Disciplined, consistent, and none of that is wasted effort. But there's a variable your cardiologist almost certainly hasn't discussed with you. It happens every night, for 7 or 8 hours, completely outside your awareness. It costs nothing to change. And for anyone over 60, the cardiovascular consequences of getting it wrong have been quietly accumulating for years. I'm Dr. Alex Thompson, cardiac surgeon. And what I'm about to tell you reshaped how I think about heart health entirely. For the better part of a century, medicine treated sleep as passive. The body powered down. The heart coasted. Doctors focused on the hours you were awake, what you ate, how you moved. Whether you smoked, sleep position was a matter of comfort, not cardiology. That assumption is now obsolete. We know today that sleep is among the most metabolically demanding periods your cardiovascular system navigates. Heart rate shifts. Blood pressure fluctuates in patterns that predict disease years before symptoms appear. Blood viscosity changes, and critically, the physical orientation of your body determines how efficiently your heart manages all of it. I spent 28 years in the operating room. Open heart procedures, triple bypasses, valve reconstructions. You develop an intimate understanding of cardiac anatomy when you've held a living heart in your hands. What took me longer to appreciate was everything that happens long before a patient reaches my table. The slow, invisible damage. The accumulated consequence of thousands of ordinary nights. That's where prevention actually lives. Not in dramatic interventions, but in what you do repeatedly, without thinking, in the dark. Here is what the research now makes clear. The position you sleep in tonight will influence your circulation, your blood pressure, your cardiac workload, and even your neurological health while you sleep. Not theoretically, measurably. No prescription required, no equipment, no dietary overhaul, no follow-up appointment. Just one piece of information and one adjustment you can make before your head touches the pillow tonight. For anyone over 60, that adjustment may matter more than you've ever been told. Let's start with something your anatomy textbook mentioned once and your doctor has probably never brought up since. Your heart is not centered in your chest. Most people assume it is symmetrical, balanced, sitting squarely behind the sternum like a logo on a t-shirt. That's not accurate. Approximately 2/3 of your heart's total mass sits left of your body's midline. It is a left-leaning organ. By design, by evolution, by pure biological architecture. That single anatomical fact changes everything about what happens when you lie down at night. When you sleep on your left side, gravity becomes an ally. The heart's natural orientation aligns with the pull of the earth beneath you. Blood flows toward the aorta with less mechanical resistance. The left ventricle, the chamber responsible for pushing oxygenated blood out to your entire body, operates with measurably less strain, less effort required. Same output achieved. Now consider the math. Your heart contracts approximately 100,000 times every single day. Not occasionally. Every day. Without pause. Without vacation. For decades. That cumulative workload is staggering even in a perfectly healthy organ. Over a lifetime, small inefficiencies compound into something significant. Reducing the mechanical burden on that muscle, even marginally, even by a fraction of a percent per beat, adds up to something real when multiplied across years and decades of nightly rest. This matters differently after 60. The heart muscle at this stage of life has already absorbed decades of demand. For many people, some degree of stiffness has developed in the ventricle walls. Cardiac output, the volume of blood the heart can efficiently pump per minute, begins a gradual natural decline. The engine is still running, and running well, but its tolerance for unnecessary resistance has narrowed. Left side sleeping doesn't reverse that. I want to be precise here, because precision is what separates medicine from marketing. No sleep position restores the cardiac function of a younger heart. What it does is remove an avoidable mechanical disadvantage during the 8 hours your body is specifically designed to repair itself. That window, those overnight hours, is when your cardiovascular system attempts its most significant recovery work. The question worth asking is whether your sleep position is supporting that process or quietly complicating it. Sleeping on your right side is not dangerous for most people. The concern isn't acute harm. It's cumulative inefficiency. Night after night, year after year, in an organ that never gets a single day off. The left side offers a clear, anatomically grounded mechanical advantage. Not a dramatic one, a consistent one. And in cardiology, consistency is everything. There's a structure inside your body that most people have never heard of. Your cardiologist understands it intimately. Your internist knows it well. And yet, in 30 years of medicine, I have almost never heard it mentioned in a routine patient conversation. It's called the inferior vena cava. The name sounds technical. The function is straightforward, and once you understand it, you will never think about sleep position the same way again. Think of your circulatory system as a two-part operation. Your heart pushes oxygenated blood outward through your arteries. That's the half most people understand. But blood must also return. Every drop that travels down to your legs, your pelvis, your abdomen, your digestive organs, all of it must make the journey back up to the heart to be reoxygenated and recirculated. That return trip is the job of the inferior vena cava. It is the largest vein in the human body. A wide, critical highway carrying used blood from everything below your diaphragm back into the right side of your heart. Here is the detail that changes everything. That vein runs directly along the right side of your spinal column. Its position is not random, it's anatomical fact. And that position makes it uniquely vulnerable to one specific thing: compression. When you sleep on your right side, the accumulated weight of your abdominal organs shifts onto that side of your body. The pressure isn't dramatic. There's no sharp pain, no obvious signal. But the inferior vena cava is being subtly compressed beneath that weight, hour after hour, through the night. Partially, quietly, consistently. Partial compression means reduced flow. Reduced flow means the heart receives blood back more slowly than it should. And a heart that isn't receiving adequate return volume compensates. It works harder, contracts more forcefully, strains against a deficit it was never meant to manage during its recovery hours. Roll onto your left side, and that pressure dissolves entirely. The inferior vena cava is free, unobstructed. Blood returns to the heart with the efficiency the system was designed to provide. For anyone over 60, this distinction carries real clinical weight. Veins age alongside every other structure in the body. Their walls gradually lose the elasticity that once made them resilient. The small internal valves that assist blood in traveling upward against gravity become incrementally less effective with each passing decade. The venous return system is working harder than it did at 40 with less mechanical advantage than it once had. Adding compression to that already challenged system is a burden that accumulates invisibly. Removing that compression costs absolutely nothing. One position, 8 hours. Every night, the benefit is real. The mechanism is established. And for your cardiovascular system, the difference between obstructed and unobstructed venous return is not trivial, it's foundational. I want to tell you something that took me years of surgical experience to fully appreciate. The most catastrophic cardiac events I have witnessed were not preceded by dramatic warning signs. No crescendo of symptoms. No obvious alarm. Just an ordinary evening, an ordinary night, and a patient who woke up fundamentally different, or didn't wake up at all. Blood clots operate with a particular and dangerous quietness. They do not announce themselves. They build slowly, silently, in conditions that most people would never think to question. Understanding how they form is the first step toward understanding how to interrupt that process. Clots develop under three primary conditions: damaged vessel walls, changes in blood composition, and the one that concerns us most in this conversation, stasis. Stasis simply means stillness. Blood that is not moving adequately. Blood that is pooling, slowing, settling in the deep vessels of the legs, the pelvis, the lower body. Most people associate dangerous stasis with long-haul flights. 12 hours in a cramped seat, legs immobile, circulation compromised. They board the plane, knowing the risk, and stretch their legs accordingly. What almost nobody considers is that a similar physiological environment can develop every single night in their own bed. 8 hours of horizontal stillness, the same deep veins, the same gravitational challenge. And depending on your sleep position, the same potential for blood to slow and pool in exactly the vessels where clots most commonly originate. After 60, the biological conditions that govern clot risk shift in ways that matter. Circulation naturally becomes less vigorous with age. Vein walls that once maintained strong, elastic recoil gradually stiffen and lose that resilience. Blood viscosity can be altered by medications. Many older adults take daily certain blood pressure treatments, diuretics, Even antihistamines can affect hydration and, consequently, how thickly blood flows through those vessels overnight. Left side sleeping directly addresses this vulnerability. With the inferior vena cava uncompressed and venous return operating without restriction, blood moves through the deep vessels of the legs and pelvis more continuously throughout the night. Moving blood resists clot formation. That is not a metaphor, it is the underlying hemodynamic principle that vascular surgeons rely on clinically. I will not overstate what sleep position can guarantee. Clot risk is multifactorial, and no single habit eliminates it. Genetics, hydration, medication, mobility, underlying vascular disease, all of these variables interact in ways that are deeply individual. But here is what I know with certainty after nearly 3 decades at the operating table. Prevention is built from layers. No single layer is sufficient alone, but each one contributes to a cumulative defense that compounds over time. Supporting your circulation during 8 hours of nightly stillness is one of those layers. It is accessible, it is free, and after 60, it is far too significant to leave unaddressed. I have spent nearly 3 decades reading peer-reviewed medical literature, cardiology journals, surgical research, longitudinal population studies. After that volume of reading, very little genuinely surprises me anymore. The glymphatic system surprised me. When I first encountered the research, I read it twice. Then I went looking for the counter-arguments, the methodological critiques, the reasons to be skeptical. What I found instead was a growing, compelling, remarkably consistent body of evidence that has fundamentally changed how neuroscientists and cardiologists alike think about sleep. Here is what they discovered. Your brain does not simply rest at night. It runs a sophisticated, highly coordinated internal cleaning operation that cannot happen any other time. During sleep, cerebrospinal fluid, the clear liquid that surrounds and cushions your brain, begins flowing actively through a network of microscopic channels woven throughout brain tissue. It moves like a slow, deliberate tide, collecting and flushing out the toxic metabolic byproducts that accumulate during a full day of cognitive activity. Every thought, every conversation, every emotional response your brain processes generates cellular waste. That waste must be cleared. Among the specific substances this system removes is amyloid beta, the protein that researchers consistently find deposited in excessive quantities in the brains of Alzheimer's patients. Another is tau protein, similarly implicated in neurological deterioration and vascular dementia. These are not obscure laboratory findings. They are the same materials that accumulate when the brain's overnight cleaning system is chronically compromised. Now here is where sleep position enters the conversation with genuine clinical significance. Research published in the Journal of Neuroscience demonstrated that the glymphatic system operates with measurably greater efficiency when the body is positioned on its side during sleep. Of the 2 lateral positions, left side sleeping appears to optimize the brain's internal drainage pathways even further, based on the directional architecture of the glymphatic network itself. This is not a comfort preference. This is drainage engineering, operating at a cellular level, every night, inside your skull. The cardiovascular connection is direct and important. When amyloid and tau proteins accumulate in brain tissue, they drive neuroinflammation, chronic, low-grade inflammation concentrated in the brain's delicate vascular structures. That inflammation does not stay contained. It compromises the small vessels that supply the brain, increases stroke risk, and contributes to the progressive small vessel disease that cardiologists and neurologists are seeing at increasingly younger ages. The brain and the heart do not operate as independent systems. They share the same vascular infrastructure. Inflammation that damages one will, over time, compromise the other. After 60, protecting cognitive health and protecting cardiovascular health are not separate goals. They are the same goal, pursued through the same interventions, including what happens during those critical hours between midnight and 3 in the morning, when the glymphatic system is doing its most intensive work, only if you are positioned to let it. I want to make a turn that may seem unexpected coming from a cardiac surgeon. I want to talk about heartburn. Stay with me, because what appears to be a digestive nuisance has a direct, documented, and seriously underappreciated pathway straight to your heart rhythm. Understanding this connection changed how I counsel every patient over 60 who mentions nighttime reflux, and far too many of them mention it casually, almost apologetically, as though it barely qualifies as a medical concern. It qualifies. GERD, gastroesophageal reflux disease, affects a significant proportion of adults over 60. The nighttime variety is particularly common and particularly damaging. The burning sensation, the sour taste on waking, the disrupted sleep. Most people manage it with an antacid and move on. What they don't see is what's happening at the tissue level while they sleep. Chronic acid exposure inflames the esophageal lining progressively, persistently, night after night. That inflammation does not stay neatly contained within the digestive system. Running directly alongside the esophagus is one of the most consequential nerves in the human body, the vagus nerve. It is the primary regulatory highway between your brain and your heart, governing rhythm, rate, and the parasympathetic signals that keep your cardiovascular system operating in a controlled, stable pattern. When the esophagus is chronically inflamed, that inflammation irritates the vagus nerve with a consistency and intimacy that proximity makes almost inevitable. The cardiac consequence of that irritation is measurable and well documented. Chronic GERD has a statistically significant association with atrial fibrillation, an irregular, often rapid heart rhythm that dramatically elevates stroke risk, particularly in people over 60. This is not a theoretical concern buried in obscure literature. It is published, replicated, and clinically observed by cardiologists regularly. The chain runs like this. Acid travels upward. Esophageal tissue inflames. Vagus nerve is chronically irritated. Heart rhythm destabilizes. 4 steps from a digestive complaint to a cardiac event. Now consider where anatomy intervenes. Your stomach is positioned on the left side of your body. The gastroesophageal junction, the valve where the esophagus meets the stomach, sits accordingly. When you sleep on your left side, that junction remains elevated above the pool of stomach acid. Gravity holds the acid where it belongs. The valve maintains its natural mechanical advantage against reflux. Shift to your right side, or your back, and that geometry reverses. The junction drops. The acid pool rises toward it. The barrier weakens. Reflux travels upward, with far less resistance throughout the night. Left side sleeping is, by straightforward anatomical logic, a structural defense against nighttime acid reflux. Less acid exposure means less esophageal inflammation. Less inflammation means less vagal irritation. Less vagal irritation means more stable, consistent heart rhythm. Each link in that chain is established science. Together, they form an argument that no cardiac patient over 60 should be sleeping without considering. There is a cardiovascular phenomenon that your doctor may have referenced in passing, perhaps noted briefly in an appointment that covered too much ground too quickly. Most patients leave without fully understanding what it means or why it matters as profoundly as it does. It is called nocturnal dipping. And for anyone over 60 managing their heart health, it deserves a great deal more attention than it typically receives. In a cardiovascular system that is functioning well, blood pressure does not remain static during sleep. It drops deliberately, measurably, by approximately 10 to 20% within the first hours of deep sleep. This is not incidental biology. It is a precisely coordinated physiological event, driven by the parasympathetic nervous system as it assumes overnight dominance. During this pressure reduction, your arteries experience genuine mechanical relief. Your kidneys regulate fluid balance with greater efficiency. Your heart muscle, which has contracted 100,000 times throughout the day, finally operates against reduced resistance and uses that window to repair, recover, and restore itself at the cellular level. This is when your cardiovascular system does its most important maintenance work, and it can only do that work if the pressure actually drops. Not everyone's does. Cardiologists classify patients whose blood pressure remains persistently elevated throughout the night as non-dippers. The clinical consequences of that distinction are severe and well documented. Non-dippers carry significantly elevated risk of heart attack, stroke, and progressive kidney disease compared to patients whose pressure follows the normal dipping pattern. The research on this is not preliminary. It is consistent, replicated, and considered settled science within cardiology. And the older the patient, the more dramatically that distinction affects long-term prognosis. Sleep position sits at the center of this process in ways that are only recently being fully appreciated. When circulation is mechanically compromised during sleep through venous compression, positional apnea, or reduced venous return, the body interprets that compromise as low-level physiological stress. Cortisol and adrenaline do not fully retreat. The sympathetic nervous system remains partially engaged when it should be surrendering control entirely to its parasympathetic counterpart. Elevated stress hormones are among the primary drivers of non-dipping. The overnight repair window closes, before the work is finished. Left-side sleeping addresses this through two distinct mechanisms. First, unobstructed venous return reduces the circulatory strain that keeps the stress response activated. Second, for people with positional sleep apnea, far more common after 60 than most patients realize, lateral sleeping significantly reduces apnea frequency. Every apnea event triggers a microsurge in blood pressure. Fewer events mean fewer surges, more consistent dipping, and a cardiovascular system that actually reaches the recovery state it was designed to enter each night. One question worth bringing to your next appointment. Ask about a 24-hour ambulatory blood pressure monitor. It will tell you definitively whether your pressure is dipping overnight. If you are over 60 and managing hypertension, that answer matters enormously. I want to step out of the general conversation for a moment and speak directly to the women watching this, because there are dimensions to this discussion that are specific to you, underrepresented in mainstream cardiac literature, and frankly overdue for a direct, honest accounting. Let's begin with something you may already know from a different chapter of your life. If you carried a pregnancy, there's a reasonable chance a doctor or midwife instructed you to sleep on your left side during the third trimester. The reason was circulatory left-side positioning improves blood flow through the inferior vena cava to the placenta, supporting oxygen and nutrient delivery to the developing baby. It was presented as non-negotiable, and most women followed it diligently. When delivery came, the instruction disappeared. Life resumed, and over the following months and years, old sleep habits gradually reasserted themselves, as habits almost always do when the urgency that created them fades. Here's what I want you to recognize. If you practiced left-side sleeping during pregnancy, even if that was 20 or 30 years ago, your neuromuscular system remembers it. The positional memory is encoded. Returning to that habit is not learning something new. It is recovering something your body already knows how to do. That distinction makes the transition meaningfully easier than most women expect. But I want to move beyond pregnancy entirely, because the conversation about women's cardiovascular health cannot begin and end there. Not at 60. Not with what we now understand about how heart disease presents, progresses, and is consistently missed in women. First, the practical dimension of sleep comfort. Women over 60 frequently contend with joint changes that make sustained side sleeping uncomfortable, particularly at the hip. When the top leg drops forward without support, it rotates the pelvis, compresses the hip joint, and creates a spinal misalignment that accumulates into genuine discomfort over the course of a night. This is one of the most common reasons women abandon lateral sleeping, and it is entirely preventable. Place a firm pillow between your knees before you sleep. This single adjustment keeps your hips stacked vertically, maintains the natural curvature of your lumbar spine, and distributes weight evenly across the joint. The discomfort that drove you to your back or your right side disappears. The cardiovascular benefits of left-side sleeping are preserved. It costs nothing and takes approximately 3 seconds to implement. Now, the more consequential dimension, cardiovascular disease remains the leading cause of death in women over 60, and it remains one of the most chronically underdiagnosed conditions in clinical medicine. I have worked in major cardiac centers for nearly 3 decades. The pattern is consistent and deeply troubling. Women present later. Their symptoms are more frequently attributed to anxiety, stress, or gastrointestinal causes. Their risk is systematically underestimated by physicians and, perhaps more dangerously, by the women themselves. Heart disease in women does not always announce itself the way cardiology textbooks traditionally describe. The crushing chest pain, the left arm radiation. These classic presentations are more reliably male. Women more often experience fatigue, jaw discomfort, nausea, shortness of breath, a vague sense that something is wrong. Symptoms that are easy to dismiss, and far too often are. Your heart is working just as hard as any man's. It faces the same age-related stiffening, the same vascular inflammation, the same nocturnal demands for repair and recovery. Every mechanism we have discussed in this conversation, the inferior vena cava, the glymphatic drainage, the nocturnal dipping window, the vagal protection against arrhythmia applies to your cardiovascular system with complete and equal force. You deserve to know that, and you deserve to act on it. I want to set aside the clinical framework for a moment and speak to you plainly. Not as a voice delivering health information, as a surgeon who has spent 28 years operating on human hearts and carrying the weight of what that work reveals. Because there are things you understand differently when you have stood at an operating table at 2 in the morning. When the room is quiet except for the monitors, and the organ you are working to save is right there in front of you, visible, vulnerable, and telling a story that began decades before this moment. I have seen what chronic vascular inflammation does to an artery over 30 years. The wall thickens, the channel narrows. The tissue that was once supple and responsive becomes rigid, calcified, unforgiving. I have seen the structural aftermath of strokes that arrived without warning in people who were, by every conventional measure, managing their health responsibly. And I have held hearts that were not damaged by a single catastrophic event, but by accumulation, by the quiet, invisible, compounding burden of thousands of small inefficiencies repeated across decades of ordinary nights. That is the damage that haunts me most. Not the dramatic emergencies, those arrive with urgency and demand immediate response. It is the slow damage, the kind that builds in silence while nobody is watching, while every involved party assumes that nothing significant is happening, because nothing significant seems to be happening, until it is. This is the context in which I want you to consider what I'm about to say. Changing your sleep position costs absolutely nothing. Not $1, not a prescription, not a referral, a follow-up appointment, or a dietary sacrifice. You are going to be horizontal for 7 or 8 hours tonight, regardless of anything else happening in your life. The cardiovascular question is simply what that time is doing to your heart while it passes. I sleep on my left side. I have for years. My wife, who practiced internal medicine for over 2 decades, sleeps on her left side. The colleagues I have shared this research with, cardiologists, internists, vascular surgeons, the overwhelming majority have made the same quiet, private adjustment in their own bedrooms, not out of certainty. Medicine rarely traffics in certainty, and anyone who tells you otherwise is selling something. We made the adjustment because the evidence is coherent, the mechanism is anatomically sound, and the cost-benefit calculation is unlike almost anything else in preventive cardiology. Zero cost, no side effects, no contraindications for the vast majority of people, potentially meaningful cardiovascular benefit compounding across years of consistent practice. In my field, we celebrate medications that reduce cardiac event risk by 18%. We consider that a meaningful clinical victory, and it is. Despite the monthly cost, despite the side effect profile, despite the monitoring requirements, we prescribe those medications without hesitation because the benefit justifies the burden. Here is an intervention with no burden whatsoever and a plausible, mechanism-supported benefit that operates every single night. And yet, in 3 decades of cardiology rounds, surgical conferences, and patient consultations, I have almost never heard a colleague raise it unprompted. We discuss statins, antihypertensives, anticoagulants, dietary protocols, supervised exercise programs. We hand patients literature on stress reduction and Mediterranean eating patterns. We do not discuss the 8 hours they are already spending horizontal, and whether those hours are quietly supporting their cardiovascular recovery or slowly working against it. That silence ends here. Every night after 60, your body initiates a maintenance operation of remarkable complexity and consequence. Your glymphatic system flushes toxic proteins from brain tissue. Your cardiovascular system enters its critical repair window, working to recover from the accumulated demands of another full day. Your venous circulation moves blood back through deep vessels toward the heart, quietly sustaining the circulatory integrity that everything else depends on. All of that happens while you are completely unconscious. You contribute nothing actively. The only question is whether the position you are sleeping in is supporting that essential work or creating unnecessary resistance against it. Let me bring everything together. 5 things I want you to carry from this conversation. 1. Your heart sits left of center. Left side sleeping aligns gravity with your cardiac anatomy, reducing mechanical workload with every single beat. Across years, that accumulation is significant. 2. The inferior vena cava runs along the right side of your spine. Left side sleeping removes all compressive pressure from that vessel, allowing venous return to operate exactly as it was designed to. 3. Blood clots form in stillness. Left side sleeping promotes continuous circulation through the deep veins of the legs and pelvis, where the most dangerous clots most commonly originate. 4. Your brain's glymphatic cleaning system operates most efficiently during lateral sleep. Better overnight clearance of amyloid and tau proteins means less vascular neuroinflammation and meaningfully reduced stroke risk. 5. Left side sleeping reduces acid reflux, protects the vagus nerve from chronic irritation, and creates the circulatory conditions that allow blood pressure to dip and your heart to genuinely recover overnight. These are not isolated benefits. They are one interconnected system, activated by one consistent nightly choice. Now, practically speaking, how do you make this transition if left side sleeping doesn't come naturally? Place a firm pillow behind your back before you sleep. It creates a physical barrier that prevents unconscious rolling without any active effort on your part. Add a second pillow between your knees to keep your hips stacked and your spine properly aligned. Side sleeping becomes genuinely comfortable when the architecture supports it correctly. Give yourself 1 week. Most people find the position begins feeling natural within days. Within a month, it requires no conscious thought whatsoever. Your body adapts, it simply needs guidance toward a better pattern than the one it defaulted into. If this conversation was useful to you, share it with someone whose heart you care about, a spouse, a sibling, a close friend managing hypertension or recovering from a cardiac event. This information should be easier to find than it currently is. Everything I've shared reflects current research and my 28 years of clinical experience. It is not a substitute for personalized medical advice. Your history is your own, and your physician knows it in ways I cannot. Please, consult them before making changes, particularly if you are managing an existing cardiac condition. I'm Dr. Alex Thompson. Your heart has been working for you, without pause, for 6, 7, 8 decades. Tonight, give it one simple thing in return. Sleep on your left side. Let it rest easier.